Vatsal. Next, we'll have the expert on wide-field imaging himself, Dr. Srinivas Sadda, or more popularly known as Vas amongst his friends and peers, is the director. He is now into artificial intelligence and image research at Doheny Institute and a professor of ophthalmology at the University of California, Los Angeles. He completed his training from Johns Hopkins University in Baltimore. His major research interests include automated retinal image analysis, retinal substructure assessment, advanced retinal imaging technologies, and vision restoration approaches. He served as a principal investigator for several trials, and he's led several international collaborative research programs as well. If I have to read his entire CV, we'll need the entire symposium, but I think I'll just let you do your talk. Over to you, please.
Okay, thanks, Chaitra, and thanks, Dr. Debashish. And thanks to Nikon and Aptos for organizing this, or allowing us to have this symposium. And thank you all for finding your way here, because I know we started late, about an hour late, because of the previous session. So yeah, I've been very fortunate to be able to work on wide-field imaging for more than 2 decades now. And it's pretty exciting to see these continued advances. And I'm going to talk about a couple of them. I'm going to follow up what Dr. Vatsal presented in his talk as well. These are my disclosures. And so I think everyone here recognizes how ultra-wide-field imaging has revolutionized how we practice retina today. And I think that maybe a comparative innovation is to think about how fundus photos and then OCT in combination have proven over the years to be superior to even what we can achieve with slit lamp biomicroscopy. And I think you can say the same now with the new innovations in ultra-wide-field imaging. I think the same can be said about ophthalmoscopy. I want to credit Eduardo Medina and the group in Italy. They actually did a nice paper where they actually directly compared getting an ultra-wide-field image compared to ophthalmoscopy with scleral depression, and they actually found a very good correspondence. And because of the fact that ultra-wide-field imaging gives you a static view, they actually suggested this should be our first-line diagnostic. Now, even when I read this paper, I've always wondered, can you really get everything you can get with what you can achieve with dynamic indentation? I think it's very helpful with dynamic indentation ophthalmoscopy to try to see vitreous traction. And this is where I very much agree with Dr. Vatsal that having peripheral OCT, I think, actually does get us to that point now. Because now, not only do you get the entire image, you can actually study those areas to see if there's traction. And so I would tend to agree with the conclusions of this paper now, as I'll highlight. I think a big area where this has been very helpful is in medical record documentation as well. Before, we used to spend a lot of time making these annotated fundus images, but now it's much better, obviously, to just simply get an ultra-wide-field image and annotate it. That's actually, I think, a much better way, because the adage is a picture is worth 1,000 words. So why do you want to make these very detailed annotations or detailed drawings? I think you can save a lot of time by simply annotating these images. The one caveat, though, is that historically, these images that are obtained through the Aptos system are red-green images. They don't have a blue wavelength, so it's kind of a pseudo-color of sorts. And that's what the latest innovation really that I wanted to focus on today is that now we have the new California RGB device where you've added the blue laser, and then you can get a color appearance that is a more natural appearing color that more reflects what all of us see when we actually examine the patient. And again, of course, you can get just with a single snap with an Aptos, you can cover a large proportion of the retina, but you can augment this further even with steering where now you can consistently get over 90% of the retina and actually visualize the ora serrata in more than one quadrant. There have been some small studies already that have started to compare the red-green versus the red-green-blue image and have shown equivalence. And I will say sometimes one of the points I wanted to make was that even though they seem to be equivalent, there are different types of conditions or different features where one may shine over the other. Now, you don't have to choose, because when you get the image, you get both for free, right? You get the red-green-blue, but the red-green is also obtained in or available to you. And I just wanted to highlight, it's interesting now that we've been able to go back and compare these, that we recognize that actually all of the information is there in the RG image. It's just that some of them are more prominent or appear more easily when you add the blue laser. There's certain features that are just simply brought out. So I guess one of the themes of this presentation is going to be that they both have their advantages, believe it or not, and that actually not having the blue can sometimes help you see certain things. I'll try to illustrate that as well. But again, the real, I think, big advantage of having this RGB now is that what you capture on the picture very much reflects what you saw when you looked into the patient's eye, and I do think that makes a difference. Okay, so in particular, I think that whitish lesions actually now really look white. I really liked Dr. Watsel's presentation because he highlighted some of these areas of white without pressure may actually be harboring areas of schisis as well. I think that's the case. Some of them, I think, really are truly areas of vitreous adherence that is truly white without pressure. But again, you can see that you lose that kind of greenish overcast. Right now, actually, whitish lesions or whitish structures appear white. Here's another example of a patient with myelinated nerve fiber. And again, you can see that the whitish, the true natural whitish appearance of these lesions becomes very well apparent. Here's another patient who I've been treating for many years, has developed areas of subretinal fibrosis, and you can see again the more natural rendering of the whitish color of the fibrosis using RGB imaging. And also for patients with retinal degenerations and other types of pigmentary alterations, sometimes these areas of age atrophy and depigmentation can be overwhelmed by the greenish hue. It's hard to delineate or understand them. And again, you can see a more natural fundus appearance. Another patient with a retinal degeneration, again highlighting the areas of depigmentation which appear more natural. Here's another patient with retinitis pigmentosa, seen pigmento. Again, you can see a pretty striking difference by adding the blue laser in this case. Here's a patient of mine with Sorsby's fundus dystrophy. Again, you can appreciate the coloration of the deposits, I think, more precisely. Here's a patient with pseudoxanthoma elasticum and angioid streaks. Again, the streaks, I think, in terms of their reddish coloration is more easier to appreciate without the overcast there. This was meant to also illustrate this patient does have some peau d'orange as well. Again, retinoschisis, I think, is something that peripheral OCT, I'll highlight, has made a big difference. This patient, you can actually see the margin of the schisis perhaps a bit more easily with the RGB image. I will say the blue laser does give you better visualization of more superficial retinal details, and I think for areas of schisis and the like, it's not surprising that could be of some help. Also seeing we've been studying a variety of different types of lattice degeneration using this technology. And again, we recognize many of these lattice lesions can have this whitish sort of appearance related to some alterations of the vessels and the like going over the lattice lesion, and that's easier to appreciate using this kind of true color imaging. Here's a patient with a rhabdomatosis detachment from Dave Brown, very similar to the case that Dr. Watzel showed. Nice thing with these optosystems is very easy to capture these images, right? Even in patients who've immediately had some type of procedure obtained. Diabetic retinopathy, we already know there have been very nice studies that have shown that Optos, the pseudocolor imaging, Dr. Rajiv has been involved in many of those, can do a good job of grading the severity of the retinopathy. And so I don't think it's because that we were missing those lesions. We see them just fine. It's just that everything, again, in terms of the coloration is rendered in the way that we might expect. More examples of patients with diabetic retinopathy. One thing I will highlight again is when you have fibrous proliferation in these patients, again, you can see the difference in the coloration, right? Like white looks white, which I think is, again, very helpful for being able to reflect exactly what we see in the patient's eye is reflected now in the image that we obtain. So I do think that there's significant value of adding the blue to the ultra-wide field platform. Another patient with pathologic myopia but you can see the whitish coloration, so the bare sclera in the areas of patchy atrophy in this case. And here's an example of a patient with Azure who you can see the areas of decommutation atrophy again more easily with the blue laser added. Now, one area where I think very clearly there's an advantage of having the addition of the blue laser is in patients with reticular pseudodrusen. This patient has extensive reticular pseudodrusen. You may recall that these lesions were first identified by Gabriel Koskas and Giselle Subran on using blue reflectance imaging. So it's not surprising that adding the blue laser will allow us to see these lesions more easily. An example of a patient with chirpy. And I want to highlight these pigmented lesions because here you can see a patient with a choroidal nevus. And I think you can all appreciate that the nevus and its borders are actually easier to see on the RG image. And that's a very consistent sort of observation that these deeper lesions, the blue laser is not so helpful, and maybe actually that additional information makes it harder to detect. Now, of course, this probably reflects more obviously what we see, the RGB image, when I examine the patient. Sometimes I've been struck by, I've examined this patient, the nevus was barely visible, and yet I obtained the Optos image and the nevus stands out. Now you can see why. Again, because the lack of the blue actually makes it stand out a bit. Here's another example of another patient with a more suspicious type of nevus. Here are more examples of nevi again. You can see that they're very well seen on the RG image. Here's a patient with a melanoma. Again, I would argue that the borders are easier to delineate without the blue laser, but this is another patient that was treated, and you can see the areas of atrophy following the application of the plaque. Patient with a choroidal hemangioma. Again, it's almost difficult to delineate the borders of the lesion. I felt it was difficult when I was trying to examine the patient. Actually, it's easier on the red-green image. So really my point of that I want to make here is that you don't lose having the red-green. You get both. You get the red-green-blue as well as the red-green. And I want to highlight that they have different benefits. I will say this is a patient with a MET and metastatic lesion, and the metastatic lesions oftentimes have a whitish kind of appearance, and you can see the whitish appearance is more easily and accurately displayed using the RGB image. And a patient with retinoblastoma, again, if you really want to have a nice illustration of the difference in coloration and something that truly is white, you can see it looks chalky white on the RGB image, just highlighting the accurate color rendition. Now, peripheral OCT was the other major big advance, and I think Dr. Vatsal did a great job of describing this. And Chaitra already went through the definitions when we tried to standardize the definitions for different zones of the fundus as well as the different regions. And I just want to say the far periphery is the region of the retina anterior to the vortex vein ampulla. And what I wanted to highlight is that wide field OCT is not the same as far peripheral OCT, right? Wide field OCT just talks about how big the scan is. Over 20 millimeters, many people would say that's going to be a wide field OCT, but that's not a peripheral OCT. Peripheral OCT means you're actually imaging the far periphery. So it's an example. You can do wide field OCT with the Silverstone, obviously, but we're talking about actually doing peripheral OCT imaging and how that can help us. And I thought I'll also show some case examples. Here's a patient, again, this is a wide field OCT, if you will, of this patient with gyrate atrophy. And I've always been curious, these little areas that you see out in the periphery, are there areas of preservation? And we've been able to study them, right? We can get an OCT. Wherever you can get the Optomap, you can get an OCT. So you can pass an OCT scan through that area, and you can see, in fact, there is no outer retinal preservation of that area. All these areas are involved in these patients' eye. We've been using this extensively to track and monitor tumors. As a patient who we treated with retinoblastoma, there's some residual regressed tumor in the bed of the lesion we've been able to follow over the years because we can scan. Again, you can obtain a volume anywhere you want in the fundus. Here's a patient with a preserved paraarterial RPE, a variant of retinitis pigmentosa, but these patients can sometimes have astrocytic lesions. Like this patient has a very vascular lesion, I might add, that we've been able to track using peripheral OCT imaging. Again, sometimes this is a pretty obviously a nevus that you can appreciate here, but sometimes we get pigmented lesions where we're not so sure, and sometimes they're so small that it's difficult to measure with ultrasound. This we found OCT to be quite valuable. This patient obviously has a very typical appearance of a nevus on OCT imaging. Again, we can get the scan wherever we want, and you can see that there are drusen overlying it as well. Here's a patient that was referred to me by the oncologist because this patient was known to have CNS lymphoma. They had new vitreous floaters. They had no macular findings, but you can see all of the abnormalities in the periphery, and we were already suspicious this likely lymphoma. But it was nice to be able to pass the OCT through there, and you'll appreciate that these are actually deposits that are located in the sub-RPE space where you would expect to see in the setting of vitreoretinal lymphoma. Again, Dr. Vatzel did a brilliant job of kind of talking about this, but we've used this as a nice tool to track and follow schisis because you can map exactly where the schisis begins and ends. I can tell you that there are many patients with schisis which were difficult to appreciate clinically, that you start to pick up and you start to wonder about your examination then. But in any event, this patient actually had such massive schisis, they even had an outer retinal hole, but we were able to delineate by mapping out the fundus. Now, what I wish we could do is we could just map the entire fundus with OCT. You can't quite do that yet, but you could if you actually took the time to do all of these kinds of scans. Okay, so I'm going to skip forward in the interest of time to point out that we've seen many patients who, again, it's sometimes difficult to make this distinction between a schisis or schisis associated with attachment. Many of these patients get laser barricade, and some of them probably unnecessarily. There are many patients we've seen who have schisis and not who thought by the referring doctor they thought that they had a detachment, but then in fact didn't have a detachment. It's just another example of such a patient. This is a patient. This is actually post-treatment. You can see a patient with dialysis that was treated with a laser in this case, and really want to highlight how you can appreciate the vitreous attachments in this case. More examples of patients with lattice generation. I also agree this is a beautiful tool to study lattice, and you start to understand the vitreous relationships here, and we'll hopefully have a paper coming out soon on this topic. And again, other lesions, which I always thought, like, is that really a cystic tuft? Well, it actually is, because you can pass the OCT through and you see that these are in fact cystic tufts. I think the biggest benefit of having peripheral OCT is recognizing vitreoretinal traction. I mean, I can't tell you how many times there are lesions that we've seen where I could not appreciate that there was vitreous traction that we could see quite easily. This patient we would have treated anyways, who had an operculated hole, but this patient was symptomatic, so I was going to laser them anyways. But there are many patients where we see this, right? So there's actually significant traction on this operculated hole, and this might redefine how we approach which patients we're going to choose to laser. So identifying vitreoretinal traction, huge beneficial aspect of having peripheral OCT. Here's a patient who doesn't actually have a break, but had areas of tractional elevation in the periphery. We scanned through this densely, and we could not actually find an actual hole. So many examples of that. I can go on and on. A lot of patients with operculated holes who still have traction. There's patients with operculated holes who don't have traction. I think those patients probably need to be treated differentially, but that'll have to be established with proper prospective studies coming up. So I want to say that there are some studies that have been done to start to look at the utility of this. Dr. Vatzel and myself showed you a number of cases, but I think systematic study is going to be useful to define exactly how we use this, although to me it's pretty apparent. But Nitin Chaudhary in Toronto, Canada, had done a very nice study where he actually found that by obtaining peripheral OCT, it changed his decision-making in a large proportion of cases, which really highlights this is not just it's fun to have. This is actually, I think, a very potent clinical tool. Example of a patient where he didn't appreciate that there was traction. This patient has evidence of peripheral traction. And again, as I said, you can image out to the periphery here. This is imaging out at the ora serrata. You can see the vitreous base in this particular patient. We've already talked about a number of different retinal detachment cases, so I won't belabor that point. You can actually even try to do OCT in these areas of detached and elevated retina, which is pretty interesting. And that's if you want to appreciate what the vitreous relationships are before you get into the operating room, I think that potentially could be useful. And this is a patient who actually had both a macular hole and a peripheral hole, as it turned out. Another example of an operculated hole from Nathan's study. So to summarize, I think we're pretty fortunate. There's been a lot of progress in ultra-wide-field imaging over the past 2 decades. I do think that the addition of the blue laser is not a small deal. I think it's a big deal because it does provide us, as I showed you with many case examples, an accurate and faithful rendering of the color of the fundus. So it really documents what we actually saw when we saw the patient's eye, and I showed you how it's helpful in whitish lesions in particular. So you can imagine in the setting of certain tumors and inflammatory diseases, that's going to be especially valuable. I think peripheral OCT really adds to this armamentarium. I think it really brings us to that point. What macular OCT did to slit lamp biomicroscopy, I imagine this is going to do to ophthalmoscopy. Thanks very much.